Ladies and gentlemen, it's my pleasure to welcome you to the Symposium Current Challenges in Combating Antimicrobial Resistances. My name is Lars Schade. My affiliation is the Robert Koch Institute, which is the German National Public Health Institute. We will have today the opportunity to have a look upon the threat by and the action taken on antimicrobial resistance from different perspectives. Annette Wittmann-Mautz, Parliamentary State Secretary in the German Ministry of Health, is unfortunately not able to join us today, but we are especially honored that Thomas Ilka has taken his time to present here today. Thomas Ilka, who serves as a State Secretary in the German Federal Ministry of Health since 2011, will give the first talk. He will contribute to today's symposium the political perspective. In particular, he will address in his talk the federal government's strategy to combat antimicrobial resistance. Dear Mr. Secretary Ilka, the floor is yours.
Are we on? Now. Very good. You can all hear me? Yes, very good. Mr. Schade, distinguished ladies and gentlemen, as Mr. Schade said, I already jumped in for Annette Wittmann-Mautz. She is, unlike me, also a member of parliament, and today the Deutsche Bundestag has its constitutional gathering, and so she must take part in all these ceremonies, and unfortunately she can't be here with you, and she asked me to give you some insight on our strategy on the topic of today. And that is what I want to do, and then afterwards I guess we can have a good discussion. For more than 70 years now, antibiotics have been our most important weapon in combating bacterial infection. Thanks to this line of defense, many communicable diseases have lost their horror. However, the successes have made us sometimes and somewhere careless. Today, antibiotics are being used too often. In addition, they are often taken in the wrong dosage, and the necessary treatment duration is not heeded. All of the foregoing, combined with a failure to observe basic hygiene measures, results in the emergence and spread of resistant pathogens. In the meantime, this trend has taken on dramatic proportions worldwide, and this is where urgent action is now imperative. Many surgical interventions, such as hip replacements or transplants, are inconceivable without effective antibiotics. But growing resistance does not only endanger the achievements of modern medicine, even infections that were easy to treat up to now could have serious consequences in the presence of resistant pathogens. Without effective antibiotics, recovery will be delayed or will not happen at all. In addition, resistant pathogens generate enormous added expense for healthcare systems. And here comes politics, of course, into play. In order to effectively combat resistance, both WHO and the European Commission have long called for the development of national strategies. This is the only way for all of the necessary measures to be coordinated. In the meantime, we know that the emergence of resistance pathogens is influenced by many factors. They can be found both in human and in veterinary medicine. They can be transmitted between humans and animals. Environmental factors can also play a significant role. As a result, a multidisciplinary approach is indispensable in combating antibiotic resistance. And this is why in Germany, both human and veterinary medicine are working closely together with the environmental sector to tackle this problem. And so here in Germany, we founded this cooperation and we provided this cooperation by DART, which stands for the German Antibiotic Resistance Strategy, and we developed that in the year 2008. And as these things are only well treated in a cross-ministry effort, the strategy was elaborated by the Federal Ministry of Food, the Federal Ministry of Health, and the Federal Ministry of Education and Research. This joint strategy allows us to take an approach that is coordinated among human and veterinary medicine, research, and the environmental sector. DART's Human Medicine section contains a range of aims and numerous concrete activities with which the federal government supports the fight against antibiotic resistance. All of these activities in this context fall into one of four categories. Category number one is the expansion of antibiotic resistance and antibiotics consumption surveillance systems. Category 2 stands for the strengthening of prevention and control measures. Category 3 stands for promotion of collaboration and cooperation. And Category 4 deals with research and evaluation. Over the past 5 years, since 2008, a number of measures have already been successfully implemented. And one example is the antibiotic resistance surveillance system that was set up at the Robert Koch Institute, of which Mr. Schade is vice president. This system makes it possible for resistance data from the inpatient and outpatient sectors to be recorded and evaluated. The collected data are then sent back to the prescribing doctors, which enables them to make a critical assessment of their own antibiotics prescriptions. In addition, a further training program was set up to train doctors and pharmacists in how to counsel patients on the appropriate use of antibiotics. The intense interest in this program illustrates the great demand for training in this area among doctors and pharmacists. One important milestone in DART's implementation was the amendment of the Protection Against Infection Act in 2011. Among other things, the amendment created the legal foundation for setting up the ART Commission, that stands for Anti-Infectives, Resistance and Therapy, at the Robert Koch Institute. This commission draws up recommendations containing general principles for diagnosis and antimicrobial treatment, focusing on infections caused by resistant pathogens. In doing so, the Commission supports doctors in their practical tasks. Both the ART Commission's recommendations and those of the Commission for Hospital Hygiene and Infectious Disease Prevention, which is called CRINCO, I love these acronyms, gained legal significance as a result of the amendment. In fact, they constitute the yardstick for hygiene standards that must be applied in implementing the recommendations on the ground. We know that this often generates considerable costs, especially in providing hospitals with the necessary infection control personnel. This is why we are not leaving our medical facilities alone in this area. We are supporting them in the recruiting of new personnel, as well as in the further and continuous training of existing personnel. In total, the federal government has allocated 365 million euros to the implementation of a hygiene promotion program. We did that last summer. Ladies and gentlemen, as you can very well see, we have already been able to achieve a great deal. Our first successes bear this out. For the first time, we are observing a slight reduction in the rate of resistance among methicillin-resistant Staphylococcus aureus strains. However, we may not allow ourselves to become complacent in the light of these successes. Reducing antibiotic resistance remains our highest priority. The emergence of new forms of resistance and routes of spread cannot be excluded for the future. Consequently, DART will be continued and adapted to current developments. Plans are in the pipeline to resubmit the strategy in revised form in 2014. In addition, we know that, thanks to increased trade and travel, resistant pathogens can spread all over the world in a very short time. This is why international cooperation is the only way to achieve long-term success in reducing antibiotic resistance. WHO has a significant role to play here. It is currently elaborating a global strategy for the containment of antimicrobial resistance. This must be supported and taken into account by all member states. Today's event is meant to provide a forum for an international level exchange of experience with antibiotic resistance control and gives us the opportunity to learn from one another. And we can do so with four renowned experts in the field. I guess Mr. Schade will give you some more details on our experts here on the level. For me, it is crucial that this conference is an international one because the problem is international and we have to find solutions together. We have to find the opportunities and to gain influence in the opportunities, to work together, to learn from one another. And I am very interested in the results of your symposium. Unfortunately, I can't take part any longer because I have an international delegation in the ministry now, which I have to go to. But my two brains, Ms. Knuffmann-Happe and Ms. Ziegelmann, are here in the room and can answer on every part of our DART strategy, I'm very sure, so that we not only have a good discussion with our four experts here, but you can have also discussions with my people from the ministry. So I wish you a very well discussion, a fruitful discussion, and please come back to Berlin. It's always a good place to discuss politics and the healthcare arena. Thank you very much.
Thank you, Mr. Secretary, for this interesting overview about the action of the federal government to combat antimicrobial resistance. And because we are already a little bit behind the schedule, the next presentation will be given by Nieke van de Zande. Nieke van de Zande is a meta-expert in antimicrobial resistance since many, many years in the Netherlands. Since 2012, she works with WHO in Copenhagen, and her main task is to set up an antimicrobial resistance surveillance scheme in the control for Asian and Eastern European countries. Today, she will talk about the WHO's perspective and action on antimicrobial resistance on the global and on the regional level. And Dr. van de Zande, we are looking forward to your presentation.
Thank you very much. Okay, so I will tell you a little bit about the current challenges from a global perspective. I only have 15 minutes, maybe a little bit less even, and so I cannot go in too much detail, but I want to give you an overview of the, as it says in my title, the challenges, but also the actions that we're actually taking now, especially at the regional office, because that's where I'm situated, together with my colleague Dr. Danilo Lofo-Wong. We are the antimicrobial resistance team, and we work together with many different programs at the regional office, but also, of course, with many partners outside of WHO on this issue. Just to give you an idea of the region where we're from, the regional office is located in Copenhagen, and so we cover the European region. This is not only the European Union, but actually 53 states, including the Central Asia and the Eastern Europe. Headquarters of WHO, which you probably all know, is in Geneva, and there's 6 regional offices. And then around 140 country offices also. I don't think that I need to explain a lot about antibiotics and antibiotic resistance in this audience. Of course, we know all the benefits that we've received from the development or the discovery of antibiotics, the millions lives saved, the increased life expectancy, and also, of course, the economic part of the more productive livestock. But with using antibiotics, you also create resistance, and which is accelerated by the misuse of antibiotics and now claiming actually lives and undermining health programs. And with the few antibiotics in the pipeline, we're actually faced with a very realistic threat of the returning to a pre-antibiotic era. Just to give you a few examples, that antimicrobial resistance is a very complex problem, which you've heard often, of course. The reason it's not a disease, but it's an extra dimension to many to actually all infectious diseases that threatens the treatment and for patients to recover from these infectious diseases. And this is a red line actually through all infectious diseases. So main challenges, that was the topic of my presentation, but I would like to shift it a bit to opportunities that these challenges also provide us in a way. And not to be too negative, but to think positive about what we can do to make the change of and trying to address the multi-complex nature of antimicrobial resistance, which automatically gives the multifaceted challenges. One of the, of course, very important challenges is improving the awareness. This room should be filled completely with people. I'm very happy that you're here, but I was hoping, of course, that the room would be completely filled. And there's a lot of there's a lot of improvement in the awareness, but this should reach all parts of the world. And very important, of course, you can have awareness, but this should actually be also translated in the change of the behavior of people in all the different levels, for the health professionals, for the patients, the public itself, but also very importantly, the policy makers. And also should result in availability of funds and structural and sustainable change. For this, of course, there's the importance of the translation into policy and actually enforcement of this policy. For instance, to stop the over-the-counter use of antibiotics, which takes place in still many parts of the world. And this leads up immediately to the need for coordination on a global, national, but also local level, of course, within the hospitals and at the general practitioners. Yet another challenge or opportunity on the other side is to improve the surveillance and also to improve the capacity to control, so that with the surveillance you will be able to, if you don't know how big your problem is in a country and you do not really know what you're facing, how can you really attack the problem? So this first step, of course, is to fill these knowledge gaps and then be able to prevent and actually intervene in this. And for this, of course, there's the need for information and guidance, and it's been said several times just now during the summary, the importance of education, education, education. For example, in terms of prudent use of antibiotics and infection control. And there's already a lot of best especially where we are now in the European Union, there are so many good examples of good practice, but it's also important to show the effectiveness of these interventions and the antibiotic stewardships to countries where this can be improved. Another need, of course, is important to be able to pinpoint. It says the burden of disease, but AMR is not actually a disease. So it's very difficult to pinpoint what really is the burden of AMR, which is needed to convince also policymakers of the importance of tackling this problem. And then, of course, finally, the lack of effective treatment options. I think this will be discussed more later on by the speakers, so I will not go into details about the importance of new business models to develop new antibiotics, and also the workshop that will come after this. But on the other side, and then, of course, if you have the new antibiotics or the alternatives, to be able to preserve them and not make the same mistake as we've done now, to use them, misuse them. And then, of course, the problem, the lack of effective treatment option is also reflected in that there's a lot of counterfeit antibiotics or substandard antibiotics, or in large parts of the world also the absence of antibiotics. And one other challenge, an opportunity, of course, is to take action. At WHO, there have been lots of since 1971, there have been lots of meetings and consultations, workshops, as you can see on all the dates that are mentioned, or the years that are mentioned, also on the World Health Assembly resolutions that have been. And of course, which I think is quite known, the WHO Global Strategy for Containment of Antimicrobial Resistance that is published in 2001, which is still very valid today. But despite, of course, there has been progress. There's been a lot of improvements made. But still, the strategies for the containment were not widely implemented. But then there was a momentum, which I think is still going on, a change. During the World Health Day in 2011, the topic was to combat drug resistance. And after that, there has been renewed efforts. And one of the things is the Global AMR Task Force and the action plan that's been developed at the headquarters, Geneva, and where there's now an actual team that's coordinating all activities related to AMR together with the regional offices and the country offices. And of course, this we cannot do without partners. And there has been technical consultation and stakeholder meetings and high-level awareness raising during the World Health Assembly in 2012 and 2013. And it's very clear from these meetings that you can see the increase, that people are starting to realize that really this is very important, because in 2012, the room was full, but in 2013, the room was completely packed and people had to sit beside the chairs and stand in the back. One other thing that has resulted from the technical consultancies is the importance of the publication of a WHO AMR Global Report, which will be published early next year, with the focus on antimicrobial resistance, to give the complete global picture of the information that's actually there, and which would also very clearly indicate the gaps that are there, and to also increase still the awareness of the policymakers of the very important issue. But that is early next year. I cannot show you yet. It's not finished. They're working very hard on it. I want to give you a little bit more about the action, that we're taking now actually at the regional office, for the implementation of the European Strategic Action Plan that was endorsed by all the 53 member states in the European region in 2011. I will not go into details of these objectives, but there are 7 action plan strategic objectives that are very concrete and actually practical for the member states to implement, and we support them with this. This is the strengthening of the intersectorial coordination, strengthening of surveillance of antibiotic resistance, and also antimicrobial consumption, promote the rational use, strengthening infection and control and surveillance in healthcare settings, prevent emergent resistance in the veterinary and the food sectors, and promote innovation and research on new drugs, of course, and improve the awareness of patient safety and partnership. I'm looking at the clock. How much more time do I have? Maybe 5 minutes?
Yes.
Okay. Yes, that okay? Okay, so one of what we do is we have country assessment with our with partners. We go to countries, and the main goal for these country assessment is that we help the country to start up with fighting actually AMR, the problem, trying to get an overview of the situation in these countries. And usually we help them with appointing a national AMR focal point, a champion in the country to start making the changes. And this person cannot do this on its own. There's the installation of it's an ICM, intersectorial coordinating mechanism, but you could also call it an AMR committee. That one of the main tasks of this committee is to develop a national AMR action plan for their country, and this we can help them with and support them. And for example, the action plan that is now developed in Germany, could be a very good example for countries that do not have a plan yet. Of course, every country is different, but still, you can help each other and support each other in this. And then one important part is the setup of the national AMR surveillance, and this we do, as the chairman already mentioned, this we do via the CSER network. This is the Central Asian and European Surveillance of Antimicrobial Resistance network to strengthen national AMR surveillance. In most of the countries we work in is Central Asia and Eastern Europe, and the European Union, and we of course have the surveillance system EARSnet, where all the EU countries are participating in. But we want to extend that to the rest of the European region, together with ESCMID and RIVM, the National Institute of Public Health. That's a lot of expertise in these surveillance activities. And in close collaboration, of course, with ECDC, that is running EARSnet. We have workshops, for instance, in several countries to help them set up these activities. And there was a CSER kickoff meeting at ECMID. This is the European Congress for Clinical Microbiology and Infectious Diseases. This was in Berlin, so this is a good place to be. So there's we go to more countries. There's a lot of interest from countries that would like our support in helping them to make changes in their country. And we're planning actually also an external quality assessment for the laboratories that are participating, for instance, in the CSER network, to see how whether the laboratory performance is the quality of their performance in the laboratories, and help them improve this. Then, on the other hand, there's for longer years there has been already initiative in collecting the use of antimicrobials in the Eastern and Central Asian part. And this is a joint initiative of the University of Antwerp and also close collaboration with ECDC to get a better picture of the situation to be able to tackle the problem. And then, of course, infection control is very important. If you're able to prevent the infection, you will also not have the problem with the resistance. Of course, a very important campaign is Save Lives, Clean Your Hands. This is a WHO global campaign. I will just go through it, not too much details, but you can always ask later if you want more details. And then, of course, there's initiatives of the problem of AMR in the veterinary sector. Not only, of course, we all know there's an excessive use, and that this also creates resistance problems in animals. And the question is, of course, how does this affect human health, but also animal health? And then, of course, we liaise with innovation initiatives, which will come back later. I will not go through details. I will leave that to the other speakers. And another part is the importance of awareness. And this is an example of the European Antibiotic Awareness Day that is organized every year by ECDC on the 18th of November. And this we want to extend to the whole of the European region to help the countries and to make these countries aware that it's important to create awareness and to have for instance, have workshops for professionals and to start up with improving the education. But this, of course, is just the start of really trying to implement, for instance, to the problem of AMR in education programs. And this, of course, is a very important slide. Partnership is key. These are the partnerships we have in Europe. And probably I forgot several of them. Finally, I would like to mention that in a few weeks' time we will have a multidisciplinary AMR workshop. It's in a few weeks in Beeldhoven, the Netherlands. This is the National Institute of Public Health, where we will invite from 12 countries 4 participants, and these all have a different expertise covering the laboratory, the data analysis, the epidemiological part, the surveillance part, the people from drug agency and from communication, usually from the Ministry of Health. These people are nominated by the Ministry of Health. And this is, of course, a very nice forum and for these countries to exchange experience, but also within the countries, that these people can start to improve their collaboration. So we're looking forward to that meeting. At the regional committee that took place last year, we presented all these actions. That's what to all the member states, that's done via a progress report. And they were all there was a lot of positive response and a lot of intervention from countries that were stating the importance of AMR, but also stating all the efforts they were already taking to try and to tackle this problem. And we had the ministerial lunch with Professor Sally Davis and Professor Otto Kars, a pre-meeting on AMR. So it's clear that AMR is high on the agenda at WHO. And I think that's how I will finish. Not to take too much time. Oh no, I didn't look at the clock. I'm sorry.
Many thanks, Dr. van de Zande. I think there is time for 2 very short questions and 2 very short answers.
Oh, there's one question.
There is a question in here by Dr. Barger.
Thank you for a nice presentation. I just have a short question. You presented that there were several resolutions from WHO because of the World Health Assembly on AMR. Is there currently planned a new resolution on AMR on a global perspective?
Yes, I know there is talk about the new resolution, but I don't know all the details of that yet. But I know that there's talk about this for the next World Health Assembly, yes. But maybe this will come up later. I'm not sure.
Thank you, Dr. van de Zande. Our next speaker is Mitchell J Schreiber from the National Center for Infection Control in Tel Aviv. Dr. Schreiber serves, in addition to his task in the National Center, which is a part of the Israel Ministry of Health, as a senior lecturer in medicine at the Tel Aviv University, and he will summarize for us the experiences of the National Center for Infection Control gathered during the 6 years since its establishment and the challenges Israel is facing. Please, Dr. Schreiber, the floor is yours.
Thank you very much, and I'd like to thank the organizers for inviting me. It's a pleasure to be here and a privilege. And I can just mention to Dr. van der Sande, previous speaker, that on November 18th, in honor of World Antibiotic Awareness Day, we are planning a major national event in Israel to recognize that day, an all-day seminar on construction of the antibiogram. So we're noting it in our part of the world as well. So it falls to me to talk about the national perspective in challenges in combating antimicrobial resistance, and so I will talk about the national perspective I'm aware of, and that's Israel's. I'm aware of others, but I can't talk about them with authority. Any of you who've read the newspapers in the last 15 years have seen headlines like these, that very dramatic about drug-resistant bacteria, many sensationalist, in some cases exaggerated, but these kinds of headlines are making the lay press as well. Are extending beyond the lay press and making the professional literature as well, and you can see more and more articles like this, including David Livermore asking, quite pointedly, has the era of untreatable infections arrived? And when a man of a stature of Livermore asks that question, you know it's time to be worried. So among the challenges we face are increasingly resistant bacteria in increasingly large numbers, limited treatment options, and limited novel agents on the horizon, and perhaps we'll hear more about that later today, an increasing global population and a shortage of hospital beds in many parts of the world, increasingly advanced medical care, and that's good news. It leads to increased life expectancy, but the result as far as resistance is that there are more people with more comorbidities getting more and broader spectrum antibiotics over more time. So therefore, resistant bacteria have a field day in terms of their ability to spread. And we're seeing more and more provision of advanced care outside of ICUs. In Israel, there's a phenomenon of ventilated patients on medical wards. And so they have all of the resistant bugs of ICU patients, except that they're not in the ICU in that kind of protected environment. And finally, we have the globalization of resistance. We're in a global world. People move all around all the time. And when people move, their flora go with them, and they are transported to other parts of the world. One subset of this globalization is medical tourism, in which case a patient goes to another part of the world directly into the healthcare system in order to receive medical care elsewhere, injecting that patient's flora into the healthcare system directly. So the CDC has recently listed its antibiotic-resistant threats in the United States for 2013, and the top three, they divide their threats into urgent, serious, and concerning. There are three threats that they characterize as urgent: Clostridium difficile, carbapenem-resistant Enterobacteriaceae, and drug-resistant Neisseria gonorrhea. Now, of these, the first two, Clostridium and CRE, are hospital healthcare-associated pathogens. In Israel, we're only now beginning to see epidemic Clostridium difficile, and this is certainly going to pose a challenge for us looking ahead. CRE we've been confronting for the last 7 years, and I would like to spend the rest of my time today talking about that. So as far back as 2008, Yehuda Carmeli and I wrote about carbapenem-resistant Enterobacteriaceae being a potential global threat. What I might say is that 5 years on, we can say that this threat has moved from potential to an actual, true, very real threat. Chief nosocomial threat among the CRE are the KPC-producing Enterobacteriaceae. A recent review published in Lancet Infectious Diseases shows the clinical epidemiology of the global expansion of Klebsiella pneumoniae carbapenemases, and in red, you have the countries in which KPC-producing Enterobacteriaceae have become endemic. So you can see in the United States, in more than half of South America, in various parts of Europe, including Poland and Southern Europe, and also in China. And this map is getting redder and redder as the years go on. The Israeli picture, in order to begin to understand the Israeli picture, you have to begin to appreciate demographics. Now, in Israel, we're a very tiny country, and we're 1/10 the population of Germany. I took Germany as an example because we're in Germany, so it just made sense. We're 1/10 the population, but we're much less than 1/10 the overall land mass, so that we're much more dense in terms of population than Germany. And not even that is the whole story, because most of the population in Israel is concentrated around the center of the country. Down here is all desert. very, very sparsely populated. And the northern Galilee is less populated than the center. So that we're dealing with a very, very densely populated country. And that doesn't tell the whole story. You also have to look at the healthcare demographics. The hospitals are getting more and more crowded. Israel, unlike many countries in Western Europe, has a steadily growing population. And unfortunately, the number of hospital beds is not increasing tantamount with the population. So that if you look at acute care beds per 1,000 people, in 1975 we're at 3.4. By 2013 we're about half that. By comparison, in Germany in 2008, the last year I was able to find an official number for, this number was over 5.5. So it just gives you some kind of a sense of what we're confronting in Israel. We're also understaffed at the levels of physician, nurse, and microbiology staff. There's inadequate infection control staffing, and there's no effective regulation of antibiotic use. Now, for the last two items, we're currently working on that. Interventions are being implemented to address infection control staffing issues and regulate antibiotic stewardship, and these efforts are being spearheaded by our national center. Medical tourism hasn't escaped us. We recently demonstrated the introduction of oxa-48 carbapenemase to Israeli hospitals by medical tourism. People come to Israel for its care from around our region and really from around the world. The New York Times recently posted an article about Israeli physicians treating Syria's wounded from the civil war there in Israeli hospitals, and these patients are coming with resistant bacteria as well that are being introduced into our healthcare system and adding to the challenges we face. So the Israeli CRE outbreak demonstrates good news and bad news. First of all, it demonstrates what can happen when a perfect storm from an antibiotic resistance point of view appears. And this perfect storm consists of an epidemiologically successful pathogen, the KPC-producing Klebsiella pneumoniae, an overtaxed healthcare system, a background of already high resistance, resulting in widespread use of broad-spectrum antibiotics, and the absence of a national detection and intervention mechanism in place, because at the time that this broke, there was nothing at the national level. But the good news is that it demonstrates that better late than never, a centralized, coordinated national intervention can still be launched and be successful. So the story in brief is that until the end of 2005, there was very little CRE in Israel to speak of. But the ST258 strain of KPC-producing Klebsiella pneumoniae was imported to Israel via the United States. We know this from molecular studies, the end of 2005. And at this point, the outbreak begins. And in 2006, there are 700 cases in Israeli hospitals. And in the first third of 2007, an additional 600 cases. So this is picking up steam as it's going along. A fully 22% of Klebsiella pneumoniae blood isolates are resistant to carbapenems in 2007. Local attempts to contain the spread at the hospital level meet with limited success only. And this bug represents a triple threat. It's very resistant, it's very transmissible in the inpatient setting, and it's lethal, with a crude mortality ranging from 40 to 70%, and an attributable mortality in bacteremia of 50%. This is the way the epidemic curve looks, just to illustrate what I've said, that until 2006, very little CRE to hear of. The ST258 strain comes in 2006, takes off, and really spreads like wildfire, increasing even in 2007. This is the pulse field gel electrophoresis, the genetic fingerprint, just to show that it's one bug. It's a clonal outbreak spreading throughout the healthcare institutions. So what was done, we divide this into two stories, the acute care story and the long-term care story. The acute care story is that in March 2007, when the health ministry became aware that this was a national threat, they acted quickly at the national level and issued isolation guidelines for acute care hospitals that required geographic separation of carriers from non-carriers in the hospitals, as well as the dedicated nursing staff, meaning that nurses who took care of carriers could not take care of non-carriers on the same shift. In addition, they created a task force, later to become the National Center for Infection Control. And our first assignment was contain the outbreak. From May 1st, 2007, up until this day, we have a daily census of all CRE carriers in acute care hospitals, including their isolation status. The implications of the above measures is that from this point on, there is a national infection control mechanism in place, and our task force is invested with the statutory authority, legally, to collect data, to make policy, to oversee implementation of the policy, and to intervene when necessary. What do we do? Every single one of those things all the time. In addition, we give feedback all the time, on a daily basis, on a monthly basis, on an annual basis, to a lot of people, but primarily to the CEOs of the hospital, the people who are ultimately responsible for everything that takes place within their walls. After 15 months, we were able to say, this is working. We saw a reduction in the monthly incidence from a high of 55.5 cases per 100,000 patient days to 11.7 cases. This is a 79% reduction, highly significant. And this is the way it looks on the epidemic curve. We see the intervention period here, and then the rise is curtailed, and we see a nice reduction. In addition, we're able to show that all of the expensive efforts at isolation work. The hospitals that are more compliant, as seen on the x-axis, have a more significant impact on the incidence to prevalence ratio. So doing what we're telling you to do actually helps you prevent spread. But it's not all roses, because as you noticed, we didn't go down to zero. We're still in mid-2008 at a kind of plateau. And why is that? Why did we reach a plateau rather than to continually reduce incidence? So the reason is that the influx of carriers continued, and this is a main part of the reason. These carriers had a history of prior healthcare exposure, and in many cases, their carriage was undetected. So they were spreading on the hospitals without our knowing about it. So that meant to us that adequate isolation of known carriers is critical. You must do what we're telling you to do with the people you know are carriers, but it's not sufficient for effective containment. We have to do two more things. One is to adequately identify the unknown, silent carriers who are having this in their GI tracts, and we don't know about it, but they're spreading it. And we also, so we have to implement active surveillance for risk groups, and this was done on a national level beginning in June 2008. And the second thing we need to do is intervene in long-term care, which represents a significant reservoir of CRE carriage. And the patients are going back and forth from long-term care to acute care. So now we go to part B of the story, the long-term care story. Beginning in 2008, the intervention commenced in post-acute care hospitals, consisting of about 3,000 beds, and these are the patients that are most likely and most frequently moving back and forth between their facilities and acute care. The goals of the intervention were to determine the degree of CRE carriage at these facilities, map the infection control infrastructure and policies at each institution, much less standard than at the acute care level, determine which CRE containment measures were necessary and feasible in long-term care, ideally without compromising the quality of care and quality of life, because this is long-term care. It's different than acute care, and we have to be consistent with the goals of the patients being in long-term care. And finally, to bring about the implementation of these measures at all post-acute care hospitals in order to reduce the reservoir of carriage and the influx of undetected carriers into the acute care hospitals, our main objective. We established an infection control score, 16 points, in order to assist us in evaluating these facilities. And they're based on 4 basic categories. Do they have an infection control consultant on staff? How compliant are they with hand hygiene? Are they appropriately using barrier precautions in the context of standard precautions? And how compliant are they with CRE prevention guidelines? We conducted point prevalence surveys. We're doing now our 4th in 2013, but I can show you the results of 2008, 10, and 11. And we've surveyed about 1,000 patients each time across the boards, across the country. And we found a nice reduction in overall CRE carrier prevalence and in CRE carrier prevalence among the patients not known to be colonized. Even better news is that this correlated with a rise in the infection control score. So as the score goes up and the hospitals are doing more of the things they need to do, their carrier prevalence is going down. In order to do this, acute care and long-term care interventions, we have established a real-time communication network. Their CRE status is a permanent part of the medical record. At all times, the staff of the National Center is aware of the location of every single CRE carrier hospitalized in the acute care and post-acute care settings, and even out in the community. All movement of these carriers between facilities and into the outpatient setting is tracked and monitored, and the receiving institution, in the event of a transfer or a new admission, is notified in real time to ensure the proper isolation in each healthcare setting. How do we measure success? 4 ways. First is a reduction in incidence, carrying out the epidemic curve until the end of the summer. We can see that there has been a steady reduction. We're still aiming for 0, not there yet, but plugging towards it. Further, a reduction in prevalence. Prior to the intervention, one of the acute care hospitals in Jerusalem published a 5.4% prevalence of CRE at an acute care hospital. Presently, among the hospitals that are doing their jobs right and doing everything right as far as infection control for CRE, focused screening of selected high-risk groups will yield at tops a 2% yield, and if you do non-selective screening, not specifically high risk, you'll rarely yield positive results. A third is the reduction in morbidity. Here, if you look at year by year, the reduction in incidence represented by the blue bars, the red bars represent a reduction in CRE bacteremia, Klebsiella and E. coli resistant to carbapenem bacteremia, and you can see a significant reduction in morbidity represented by bacteremia over time. And finally, the achievement of the primary objective is a measure of success. The wards in the ICUs have remained open with ward closure only rarely needed and always brief when needed. And this was far from a foregone conclusion back in 2007. So at the national level, the goal of allowing acute care hospitals to continue to function safely has been achieved. So wrapping up, 3 summary slides. CRE is endemic in Israeli healthcare facilities. The primary goal of the national intervention, to contain its spread in the acute care setting, is achieved, but it's an ongoing work in process. But the pillars of our approach remain effective. That is, patient isolation according to ward-type-based guidelines, dedicated nursing staffing in acute care, active surveillance, uniform standards across the boards of detection and reporting, central supervision of adherence to infection control guidelines across the system, and a real-time response when necessary. The Israeli experience demonstrates that even when CRE has become endemic, its spread can be contained, and safe conditions in the healthcare setting can be reestablished and can be sustained. In addition, it shows us that recruitment of the healthcare system under a centralized authority enables the Ministry of Health to tackle additional pathogens and additional issues in infection control. We all know that CRE isn't the only issue we have to deal with. Continued success is going to require the recruitment and continued vigilance at every single level of the healthcare system, from the top on down. It remains to be shown whether eradication can be achieved. A late start enabled the establishment of a large reservoir of carriage, which we're still dealing with. And that brings me to my final take-home message to the audience here. Don't try this at home. Our experience should serve as a warning to nations and regions in which CRE is still rare or absent. You must be alert and prepared for its appearance, and you must have a centralized plan for detection and isolation in place. I'd like to thank all of my colleagues in Israel who have helped in a tremendous way in carrying out this program, and I'd like to thank you for your attention. Thank you very much.
Many thanks, Dr. Schreiber, for this very concrete example for outbreak control and giving us as well the evidence that these control measures have worked. So, 2 short questions, please. Yes, please.
Hello, thank you for this nice presentation and congratulations. It's encouraging to hear some positive news on this big issue. My question is, do you have any information about hospital environmental spread in the hospital and in the community in Israel about antimicrobial resistance? Because as you've shown, the patients you seem to have under control. What's about the environment? Thank you.
Interesting. Thank you for the question. The question was about, do I have any data about environmental spread? Environmental tracking and spread hasn't been part of the surveillance that we're carrying out at the national level, although we do insist when we do our site visits that hospitals adhere to national guidelines for cleaning and disinfection of equipment and the hospital environment. There are data that are being assembled by local individual institutions, and I expect that that data will be forthcoming. So even though it won't be coming from the national center, look for it in the literature. It should be appearing shortly.
Thank you. So this was a little bit longer question and answer. So if there isn't any very urgent question, I would like to invite our next speaker. The following talk will be given by, many thanks again, Dr. Schreiber, will be given by Mats Ulfendal from Sweden. Mats Ulfendal is a professor for experimental audiology and otology at the Karolinska Institute, and in addition, Secretary General for Medicine and Health of the Swedish Research Council. In today's talk, he will emphasize the global nature of antimicrobial resistance and the need for joint actions. He will introduce the Joint Programming Initiative, underlining the need for true member states' commitment. Please, Professor Ulfendal.
Thank you, Mr. Chairman. So rather than talk about research policy considerations, I would like to touch upon how the processes we have to implement research policies. The first speaker touched upon the problems of implementing strategic plans worldwide, and theoretically it would be easier to implement research policy plans, but it's a long process and I will discuss this today. So I will do this from two perspectives, one as a representative of a funding agency, the Swedish Research Council, and one as a representative of the Joint Programming Initiative on Antimicrobial Resistance, where I'm chair of the management board. So all this is about drugs. You understand it, of course, already while you're here. And this is also familiar to you. The more we use antibiotics of different types, the more the risk of developing resistant bacterial strains. And this is expected, and this was already highlighted by Alexander Fleming in his speech when he received the Nobel Prize in 1945. He outlined that this would happen if you don't use antibiotics in a sensible way under restrictions. The overuse of it will lead to development of resistant strains. And this is biology. This is what should happen, and it does happen, and we're now in a situation where this is causing major problems, as has been touched upon by the previous speakers. So looking at this graph, you could, of course, argue that those of us belonging to countries at the lower end of this, or lower part of this graph, we could sort of say this is not our problem and leave it to those at the upper part of it to deal with the problem. Of course, that doesn't work. Illustrated in this slide, which describes the spread of resistant strains through, well, in this case, from Spain throughout Europe or throughout the world. So this is very much of a global problem. We cannot sit in our own countries thinking that we solve the problems and let other people or other countries deal with it. We have to do this together. So there are a few facts which I think we can all agree on. Antibiotics are used much, much more than they should. And we have too little restrictions on how to use it in different parts of the world. The number of resistant strains is increasing all the time, and we don't see any plateau or ending to this. There are a number of deaths in society to this. The costs of society are enormous and increasing. The pharmaceutical companies are not able to produce the antibiotics in the way they did before, so we have very, very few drugs in the pipeline from the pharmaceutical companies. So we can't say that, well, there's a new bacterial strain coming up which is resistant, so we use another drug, because these drugs are not available anymore. And finally, which I think is the most important take-home message here, this is a global problem, something we have to address together. So with all major societal challenges, we have to do something together, joint and coordinated actions or plans or programs. In Europe, we tend to look at the European Union from the member state perspective and see how this could be done or solved at the European level. And the European Union actually has a very ambitious and bold vision of establishing what is called the European Research Area. And the European Research Area is to form or to establish a region of Europe where research projects, researchers, and everything related to research actually can move freely in order to increase the competitiveness of Europe in science. Easy said than done. There are a number of instruments that have been developed to try to fulfill this European research area. I think the original plan was to have the European research area developed by 2014. That has been adjusted a bit, hopefully, and by natural reasons. And one of the instruments that have been suggested is joint programming. Joint programming is very much about coordinating actions in different member states, trying to do things together, to use resources together, to coordinate programs and national plans. So the European Union wants to have a European research area, suggests joint programming, and then shifts the responsibility back to the member states. And this sounds like a way of getting out of the problem from the European Union point of view, but that's not the case, because if you look at the resources available for research in Europe, the European Union, through the European Commission, controls less than 10% of the available funding for research. The rest, more than 90% of all available funding for research, is controlled by the member states. So if you want to address a major societal challenge, you have to commit the member states and their resources. So back to the member states, try to get involved in joint programming and see what we can do. And that takes me to the Joint Program Initiative on Antimicrobial Resistance, which we talked briefly about. So this started end of 2009 with a proposal from Sweden, actually, to have a joint programming initiative on this topic. This was followed by a meeting in Stockholm in 2010 in the spring. And later this spring, we submitted together with Italy a proposal for a joint program initiative. This was processed. While this was being processed, we had the first management board meeting. At that point, 14 member states or associate states were involved. I think this was a good idea, and that's something that could lead to some joint actions to meet the challenges. End of 2011, we finally got the Council recommendations and finally the Council conclusions, which meant that formally we were a joint programming initiative. So we were established and considered as something sort of real in this context. As a consequence of being approved, we were able to apply for money from the European Commission or funding from the European Commission to support the starting work of this joint program initiative, essentially the administrative cost of running a joint program called a coordination and support action. And this was approved, and 2012 in September, more than a year ago, we started the work of the coordination and support action. A little time ago, we had our 14th management board meeting, and at the end of this year, the strategic research agenda will be adopted. The strategic research agenda is a joint description established by a number of very prominent European and national scientists. What are the main important questions related to antimicrobial resistance? The aim, as indicated, is to minimize antimicrobial resistance. And this rests on a number of pillars, from therapeutics, diagnostics, surveillance, transmission, environment, and interventions. And all of these are described with what is suggested to be done within each of these categories. As I said, this is formulated by a scientific advisory board. We are now discussing this with national expert panels in all the countries involved in this. We have had an online consultation which closed last week, where we take in comments from anyone who has a view on the contents of this agenda. We're discussing continuously with stakeholders to get their view on this in order to have this document as broad as possible, to include all the important things, but also to have it anchored in society, that scientists, stakeholders, society as a whole agrees that this is important, and what is described here reflects the problem. As I said, this is to be adopted at the end of this year, and it will be officially launched probably in March of next year. And next year, we are now discussing a first joint call, and that will be out early next year, early 2014. And this call is together with Canada. It relates to the first of the pillars related to therapeutics, so essentially about finding new molecules or compounds for new drugs. So it's a very broad call. It relates very much to fundamental research. And this is taken from the preliminary call text, which we're discussing right now. But we expect this to open up at very early January next year. So this description of what we've done was not really to take you into all the details of our joint program initiative, but to illustrate the sequence of events that are required to get to a point where you actually can start doing something. So it's more than 4 years from the first proposal to we'll actually have a call, which I guess it's a beginning of implementation. This is a long time, and I sometimes think this is way too slow. However, I think it's extremely important for the member states that participate in this that they learn to know each other and respect each other and respect each other's processes, for example, for announcing calls or quality control or programs. Because if you're going to do things together, we have to trust each other that every country part of this can actually do or fulfill its requirements. So the build-up of trust is actually the most important of this part, which is taking quite a long time. We are right now 19 members of the management board, and 19 members or countries participate in this work. We also have the European Commission on the management board, and they're very supportive to what we're doing. I highlighted Canada here. It's the last country or latest, I should say, country that joined us. And I highlighted Canada just to emphasize that we do not see the work we do in this joint program initiative on antimicrobial resistance as something which is limited to Europe. This is a global problem, and we certainly want other countries to join us if they can agree on the guidelines, or not the guidelines, but the direction of this work. Canada is not a country with large problems with antimicrobial resistance, but they symbolize that we want to go outside of Europe and to include as many countries as possible that are willing to act to solve this challenge. When I talk about joint programming to researchers, primarily in Sweden, they always start asking, where's the money? Where can I apply for this? When will there be a call? And I always say that joint programming is much more than calls and funding for research projects. It is, as I touched upon already, it's of aligning the programs in different member states to make the best use of our resources. But the main question is not where the money is. The main question, I think, is who owns the question? Whose responsibility is it to fulfill these plans? And I think that goes for all the strategic plans or research plans that we're discussing here. Me representing a funding agency, I can just say that we can do, what we can do is relatively limited. What we do is directed by our assignments and our mandate. So I would like to emphasize, in order to make any of the plans or the policy that we're discussing and mentioning here, realized we have to get the political commitment from all the member states to actually give us the tools to do this. So without the political commitment, anything we're talking about here in this context is meaningless. This is a global problem, and we need all the member states to establish the instruments that we can use with much more strength than we have done so far. Thank you.
Thank you, Professor Wolfendahl. There is space, there is time for some questions, because you have brought us back to the schedule. Thanks for this as well. Are there any questions? So one question is, partners of this program, are these mainly universities and academia, or as well governmental organizations in this joint programming program?
Well, I would say that academia is doing the best to solve their issues, but in order to make the coordination happen and to make us to use resources in a more efficient way, we definitely need the support from the political structures.
Thank you. This is a wonderful presentation. I saw this may be the issue and partnership in the European country, but the superbug did not originate here. It originated somewhere in Asia, and that was affected to USA and Europe. So I don't see any country which is really having antibiotic resistance problem in a big magnitude is involved in your partnership. So that is accidental or intentional?
No, that's an effect of this being a European Commission initiative, or European, or the member states of the European Council to take the initiative to joint programming. But we have really emphasized in our internal work that we would like to reach out to the other countries outside of Europe to include them, because, as I said, this is not a problem that can be solved in Europe, and essentially the problem is relatively limited in Europe. So yes, we definitely need to get other countries involved to solve it.
Next question,
Hi.
please.
Mary Murray from REACT. Thank you, very interesting presentation. I agree with you about trust above everything. Building that is absolutely invaluable. I'd just like to ask you, what then would be the process for other countries from other regions coming in? I'm thinking not just of Asia, but Australia, Latin America, Africa, for example. What is the process?
Send us a mail and we start a discussion. We're very pragmatic about this. We do have terms of reference. The countries that want to join us, of course, have to apply, but the management board will certainly approve countries that want to join. What we need in this group, in the management board, is countries that really want to do something, and not just sit there to follow the development, but actually to do something. Otherwise, again, it's meaningless. We're not there to establish new policies and documents. We're there to actually make a change. And I realize that will take some time, and there will be a number of policies and papers in the meantime. But if we don't have the true intention of making or doing something, and to have the commitment of the country that is entering this work, then no idea, no point.
Yeah. Oh, that's great. Thank you.
Last question, please.
Yeah, thank you for your presentation. I just wanted to ask if there are other countries who will join the initiative, or do you know that they are thinking about joining the initiative besides Canada and besides Europe?
Well, Malta is following us as an observer, and there are a couple other countries that have asked for more information, and we have not done any systematic approach to get more countries involved, because we don't see our progress or success as the number of countries being involved. So we want the countries to be involved that really should be sincere about the questions that really want to do something. And if they're interested, yes. And of course, when we're out in places like this, of course, there is an opening for discussion with different countries.
Thank you again, Professor Ulfendahl. The last presentation will be given by Otto Kaas, as well from Sweden. Otto Kaas is a professor for infectious diseases at Uppsala University. He has been involved in a number of European and international activities during the last years on antimicrobial resistance. Currently, he is engaged in the interactive network, international actor REACT, Action on Antimicrobial Resistance. And in his talk, he will demonstrate the lack of a coordinated and multidisciplinary approach against antibiotic resistance in most countries, and the urgent need for an unprecedented global collaboration in the field. Professor Kaas, the floor is yours.
Thank you very much for the introduction. Thank you for the Ministries of Health and Education in Germany for the invitation to this meeting. Just a few words on REACT. It's an international network, well-rooted in civil society, in the professional organizations, and in policy in many of the regions in the world. We are supported by the Swedish Agency for Aid, SIDA, and hosted by Uppsala University. Bridging the gap between science to policy. There is a lot of knowledge. This is from the PubMed database, where the entries is antibiotic. You can see the exponential curve in knowledge, but the exponential curve in action is lacking. This is where we are. We have a crisis in the world, and who's responsible? I picked that up from Mats' talk. I come back to that at the end. We need unprecedented global collaboration. We have heard a lot here from WHO, really good stuff with limited resources, research collaboration, also fantastic interventions on the national level. Things can be done, but we need simply to speed up this. This is not working, showing PowerPoints to each other. We have to act. You have to bridge a very scientific, technical, difficult to understand issue, at least for a policymaker, to policy and political and social action. This is what is needed. Why the complacency? Well, I think that there are many answers to that question, but I think basically it's a technical thing. It doesn't have a disease phase like HIV, tuberculosis, malaria. It's not well understood. It's undermining many diseases, but it's not a disease. There are very little data on the global scale on antibiotic use and resistance. Still, there is an urge for this. There need to be a global surveillance system. There need to be measurements in all the world, but it isn't there. And moreover, the burden of disease is not visible. So how to convince a policymaker if you don't know how many people are dying? We need the data. But lastly, I think one primary thing is that we have been moving into a self-deception that there will always be a new antibiotic around the corner when we have used up the old ones. I think many people still believe that that is the case. It's not. In the meantime, we are wasting the resource we have. This is China, where children with common colds get intravenous antibiotics. You can see the magnitude of use in China, 138 grams per capita per year, in Sweden 7 grams. This is massive, massive overuse of this resource. Sales of antibiotics in Mexico, sales of antibiotics in the US. What is this? Now the US government is back. I think they should do something about this. In Europe, still, there is a law in all EU member states that antibiotics should only be prescription drugs. It's not enforced. These are similar clients in Greece. 100% of them could get antibiotics and amoxicillin without a prescription, 50% quinolone. This is not acceptable. So what is happening with our fantastic resource? Well, we're undermining not only diseases, many diseases, but also procedures, as was already alluded to in the introduction from the ministry. We're losing what we have been building up for 70 years. We're entering the post-antibiotic era. But remember, many countries in the world didn't even enter the antibiotic era because there's lack of access. We're having a paradox. Antibiotic resistance is going up, drug development significantly going down or even stopped. There is a lot of consequences, but the vicious circle number one is there's really no data to convince for the policy level, and there's no awareness, and there's no priority, and no funding, and we're moving in that circle. One way to try to break that was during the Swedish presidency of the EU, where we in REACT talked to the Director General of the EMA and the ECDC, the agencies in the EU, and convinced them to do what we call a gap analysis together with us. And that was this document, and the figures has been circling around that 25,000 citizens in the EU die yearly. That was an old figure and is significantly underestimated, but it's still a figure. And it helped a lot to convince that this is a real problem. And it costs a lot of money and a lot of extra hospital days. Now, again, the CDC report that was mentioned says that there are 2 million resistant infections in the US and 23,000 people dying. So there is a significant burden. But we don't have the full magnitude. And the burden disproportionately falls on the developing countries, on the low-income countries. The tip of the iceberg. We don't know much. As you can see, this iceberg has the shape of Africa. But there is environmental issues, there's a lot of money, mortality and morbidity, and we don't really have the full picture. It's much, much bigger than anyone can believe. It's threatening healthcare as such. We know that in Tanzania, children are dying in gram-negative infections. The mortality in a well-conducted study in Tanzania, in Dar es Salaam, gives these figures. The mortality is high when the children catching a gram-negative infection in the blood. In fact, in that hospital, the rate of death for malaria was only 20%. So this is a significant issue, also in low and middle-income countries. A study commissioned by REACT says this: in 5 Asian countries, a child dies every 5 minutes because of the drug that's given for infection is not working. Who is responsible? it's closer to us. It's not only Israel, US, over there. It's here. This is Italy. And these KPC strains are moving also in our region of the world. And we have also seen this kind of infections in Sweden, where we have only 2 very not so good drugs to choose from for severe infections. It's there with us. Second vicious circle, the failing machinery. We believe that the industry will deliver new drugs. They have, but no longer. New antibiotics has been marketed, overused, we have got resistance, it's triggered new development, and this has been moving along. For 70 years it worked, not any longer. This is from the World Economic Forum that raised this issue in January. You can see the discovery void. These are the classes of antibiotics developed over time. And you can see from 1987 until now, there's no single new antibiotic class discovered. There were a few classes launched in the 2000s, but they were already discovered in 1987. And in the clinical development pipeline, there is no single new class for antibiotics for the gram-negative bacteria. We're completely out of them. Also triggered by the Swedish initiative during the Swedish presidency, the EU Commission came up with a plan to secure effective antibiotics. And it says to promote a staged approach, unprecedented collaborative research and development efforts to bring new antimicrobials to patients. And this is now happening. There is something called IMI, which is a private-public partnership between the EU Commission and the research-based European pharmaceutical industry, where a lot of upfront funding now is placed in a collaboration to get new antibiotics. It will take time, but it's a very good initiative, and it's, I think, the best of its kind today. But the full business model, as will also be discussed in some more detail in the workshop after this symposium, is not there yet. We need to have a needs-driven approach. We need to solve together in an open way, an open collaborative way, the significant scientific challenges. This is not only a financial problem or a regulatory problem. It's really basically a scientific issue that need to be dealt with in collaboration. We need to have incentives, of course, to stimulate R&D. For these prioritized antibiotics, but the incentive should be such that we can de-link return on investment from sales. We don't want these new precious drugs to be sold in the market. There need to be incentives earlier on that buys out or supports the producer, of course, need to get paid, but not by big sales and marketing. We need to have a controlled distribution, and we need to have equitable global access and affordability. This business model is the only sustainable way forward, and I think it's going to happen. It must happen. I think the discussion is now ongoing in many policy circles to discuss this new sort of way forward. We also need to reframe the issue. We're talking about antibiotic resistance or antimicrobial resistance. Why not talk about access to effective antibiotics instead? I think that is a much better way, because access to antibiotics is really essential for any health system in the world, even the weakest. It's a health security issue. It's about universal health coverage. It's about sustainable development, and it's definitely about ecology, environment, and One Health. So I think we need to place this issue in those discussion fora also, and not leave it out of the technical discussion. It's much bigger than that. World Economic Forum raised it. I haven't heard much since, but it's there. Dame Sally Davis, the Chief Medical Officer in the UK, has really been a major driver here and put it in the civil register of risks, national risks, together with flooding, terrorism, and maybe other things. This is a good sign that someone on that level really understands how big this issue is. We need to have a civil society movement also, a public health-driven movement to really make people understand what precious drugs the antibiotics are and how they should be used. And this is from REACT Civil Society project run in Latin America, Africa, and in Asia. So at the end, we need a health policy agenda that is taking this up more strongly. We need a global partnership for collaboration. This partnership should be on the national governmental level, of course, on the civil society level, but not the least on an international organization level and the donors. Where is the money? Bill and Melinda Gates Foundation has not yet been entering this space. We have the Global Fund for TB, malaria, and HIV. We don't have a Global Fund for antibiotics. We need much more strong financing bodies. WHO can take some leadership, but need also to be supported. This is far beyond health. Many other agencies need to come on board. So we need maybe something called a global panel, Global Antibiotic Commission, like climate change, something very, very much bigger than we have today, to drive this global issue forward. To support the countries that cannot afford to implement national strategies, and also really doing educational activities to reduce demand in those areas where there is no prescribers, when you just go buy the medicine in the shop, to really try to minimize overuse that way. Focus on prevention. Very simple things are not implemented. Soap, water, clean water, alcohol. It could save millions of lives. It needs to be scaled up significantly. And again, we need to develop a new business model that secures the access for antibiotics for the future, starting now, and also make access to effective antibiotics an issue like for development, like already TB, malaria, and HIV is. These circles, again, need to be merged. There's huge lack of access in many areas of the world. Just 1/3 of children with pneumonia in sub-Saharan Africa get antibiotics at all. So that we need to take this, and it needs to be global. Antibiotic resistance, as long as we use antibiotics, will not go away. It will stay with us. We just have to manage it. We can never get rid of it. We can never solve the problem. We just have to manage it. And we have to do it together. If we don't get rid of the overuse and the misuse and this mismanagement of this global resource, what's left? Well, clean water, if it's there. So I think antibiotic resistance is a real challenge. We need a rescue plan for antibiotics, but also this is in fact a rescue plan for health, for healthcare. And everyone is responsible, but we need to put together something bigger together with, under, I think, the leadership of the WHO. Thank you very much.
Thank you for Professor Kaas for this interesting talk. Are there any questions? There is, I think, some time for questions. Yes, please.
But it's just a curiosity. It's both presentation comes from Sweden, one from Swedish Medical Research, another from University from Sweden. It happens that it's originated an issue from a country which might have the lowest antibiotic resistance in global comparison. And just how the organization called REACT is working in relation to health system to other country where they are working. It's working in isolation like NGO, or it works with the health system of the country where it is working? That was my concern.
REACT is really in the midst of a transition phase. First of all, we are not an NGO. We are a university-based global alliance network. We are moving into the structure of becoming an NGO. We have limited funding from SIDA. What we try to do is to work with the people that are engaged, the champions, the leaders, and start wherever there is a person. Might it be on the civil society level, or professional level, or a policy level. But just to give one example, in Ghana we are supporting the building of a national policy program, fully built out with all the stakeholders, civil society, media, all the ministries that should be included. So that's one way of doing it. Really, at the end, I think that we are trying to support the implementation of a national policy program. But you have to start where there are people that are engaged.
One more question, please.
Sorry, I being interested in that area, I am closely working with the government to implement the policy to save antibiotics as much as possible. I'm from Nepal, so from developing countries' perspective, I can share with you that this is an opening of Pandora box, because there is a non-regulated antibiotic counter sale, and there is a possibility that all sorts of health workers prescribe the antibiotics, and the government, which unless we involve the health system of the country which is regulated and maintain the policy, the patch-up work may not give the result we desire for. That is the only worry, that this type of activities, when we are taking a global level, we need to work with the health system of that particular country to bring any changes. That's just here.
There's definitely no one size fits all, but the components, all the components are there. They are identical in all countries. They need to be together, but it need to be in the context that you work, absolutely, yes.
Very shortly, please.
Okay, I have a two-part question. So the first one concerns the first talk, and the second one is a general question concerns another talk. So, Dr. Kars, you made this comparison with climate change, and that we have to address this problem as we address climate change. I wonder what the other panelists think of this comparison, because this also puts the problem in a similar dimension as climate change. Is it really such a big issue? And the second question concerns Mr. Schreiber's talk, where you mentioned that you track transmitters, and maybe you could give one more detail. I mean, how precise is this tracking? And so my question, because I'm a German journalist, is could you imagine something like this being done in Germany? Do we need something like this in Germany? And so a question to the German side and the European side here, is something like that feasible at all in Germany or on a European level?
Okay, can you hear me? So I just want to make sure I understood the question. You mentioned something about treating transmitters, tracking. Maybe when you mentioned that you track transmitters at all times from some. Okay, tracking transmitters, exactly. Detecting and tracking patients who are carriers. That is something that we do. You wanted to know whether I think a similar program is feasible in Germany? Well, I think it really depends on the structure of the healthcare system. In Israel, it's a small country with a centralized health ministry that is responsible for all of the healthcare institutions. One ministry licenses all of the institutions. If I take, for example, the United States, where I was born, there's 50 state health boards. There's no one federal, there's a federal regulatory authority, but there are 50 state health boards, and the policy management and oversight is not controlled at the federal level in the areas that we're talking about. And I think the way to focus is you want centralized regional oversight policy and making sure that policy that is created is implemented. So it might be that, and I'm not enough of an expert on the way the German healthcare system is structured to answer, but it might be that there should be a nationwide approach from the health ministry to what policies need to be implemented, but in terms of managing the implementation, that would be done at the regional level. And there is in the literature successful examples of regional approaches and regional interventions in CRE control. So however the system is structured, wherever you can make the centralized, at whatever level you make the centralized approach and the centralized authority that's enforcing it, that's where you should carry it out. Did that answer your question, or did I just confuse you more?
I was also concerned about such issues we have here in Germany.
I'm sorry, but I have to stop here because Professor Kars has his own workshop in very few minutes. So if you have some specific questions to one of the speakers here, I would like to invite you, and I think they will agree to do this on a bilateral basis after the symposium is closed. So I'm sorry. So I would like to thank all the speakers, and especially Professor Kaas for the last talk and all the questions.